My name is Margaret Fitch, and I am to be your moderator for today. We are delighted to be able to introduce Kristen Hawes. She may be familiar to many of you, but I think it's wonderful that she is agreeing to be with us today and share her perspectives on older adults. Kristen is an associate professor at the School of Nursing at the University of British Columbia, an affiliate scientist with the British Columbia Cancer Research Institute, and a health researcher, British Columbia scholar. She leads the Access Lab, which has a focus on aging, on cancer, and support for older adults. And she also is a leader of the Nursing and Allied Health Scientists group with the International Society of Gerontology. So Kristen is a colleague of mine. I'm delighted she agreed to present today. And on that note, I am going to turn the podium, if you will, over to her.
Thank you, Marg. Thanks for the introduction and thank you for the invitation to speak today. Whenever Marg asks me to do something, I will always say yes. So you know that now. That's always Marg is such a leader in the field in survivorship care, and so thank you very much for the opportunity to be here today. Today, I'm going to be talking about supporting care for older adults with cancer, and I am really going to be focusing quite a bit on the nursing role, but I think it's something that we can all think about how we leverage different roles to enhance care for older adults with cancer. I have no conflicts to disclose. So, from today's talk, we're going to talk a little bit more about the unique and distinct needs of older adults with cancer. I would like to talk about the current status of research in general and nurse-led research related to clinical services and care for older adults with cancer, and talk a little bit about opportunities for future clinical models and approaches. I think I missed my land acknowledgement slide. I'm not sure where it went, but I would just like to acknowledge briefly that I do live and work on the traditional, ancestral, and unceded territory of the Musqueam people here in what's known as Vancouver. And I am very pleased to be able to live, work, and play on this territory. So, I think probably most people are aware of the demographic changes that are taking place in our society. And these figures here show the changes in percentage of population over the age of 60 by region, looking specifically at the areas, the times from 1980 to 2050. So you can see that globally, the percentage of the proportion of the population over the age of 60 is growing globally. And that impacts basically everything. I remember when I went to nursing school, we talked a lot about what was going to be happening in terms of demographic changes, and that was 20 years ago now. And unfortunately, I don't think our systems have changed a lot to adapt to what we knew was coming, which was a major demographic shift. And one of maybe you're aware, maybe you're not, but based on the amount of traffic we've had on this op-ed that I wrote with Dr. Shabir Alibai, related to the leading risk factor for cancer, really one of the leading risk factors for cancer is aging. As we age, we're more likely to develop cancer. And so that's why we see these growing rates of cancer. In British Columbia, the number of older adults diagnosed with cancer, so over the age of 60, is 78%. So that's nearly 80% of all new cancers occurring in that population. So there's some argument to be made for the idea that cancer is an older person's illness. And so how do we think our systems are currently meeting those needs? And why are we having these conversations? Partly because, they aren't being met. These needs aren't being met. We don't have specialized services for older adults with cancer, even though we have clinical guidelines that tell us that we should be doing things differently and doing things better in order to improve quality of life and reduce treatment toxicities. So what does make older adults different? We're saying that they're different and they need different things, but what does that look like? And I apologize because this is a bit of a wordy slide, but it's important to consider all of these things. So First off, we know that older adults have less life to live, so they have less life expectancy. And this can impact the benefit of treatments or the benefit of their perception of treatments. So, being able to have a frank conversation about what that means to an individual patient is really important. We also know that older adults have different pharmacokinetics and dynamics. They'll process treatment differently, and they may tolerate treatment less well than someone younger and with less coexisting chronic conditions. So we have to consider that as well. Most also have other chronic conditions. Most older adults over the age of 70 have more than one chronic condition, and this also impacts treatment risk and benefits. There's also an increased likelihood of cognitive and functional impairments. Functional impairments also include changes in mobility, and we know that if folks are already vulnerable to these things, this could be impacted and made worse by some of the treatments. There's also an increased likelihood of frailty in this population, and we don't do a great job of identifying and addressing frailty. That's a fairly global statement outside of a few, pockets of excellence when it comes to cancer care. And we also know that in cancer care, one of the big challenges actually is ageism. And this is an insidious problem generally. A lot of work has been done to sort of think about why this exists. We know that folks are really happy to discriminate on the base of age in ways that they wouldn't do for other things. And this is very much a socially accepted form of discrimination that, we might say, we're not ageist, but many of our systems actually are ableist and ageist. So it is a factor that impacts care for older adults with cancer. And as a result of all of these factors that impact our systems at the individual and structural level, there's less evidence about how to best treat and care for older adults. And so this is where comes the field of geriatric oncology. And I think, although I might be speaking out of school here, the sort of first discussions about geriatric oncology started to take place in the early 80s. I want to say 1983. And so geriatric oncology is an interdisciplinary field which integrates principles of oncology and geriatrics to optimize cancer care for older adults. And one of the things about geriatrics that's really wonderful, and I always say when I grow up, I'd like to be a geriatrician because I think they have the best job, is that they really center what matters most to the patients. And I mean, I think a lot of us who are doing any kind of clinical practice would say, yeah, we all do that. We do center what matters most, but it is done in a very intentional way. Geriatricians also, geriatric oncology also is very multidisciplinary. So the idea is there is a large emphasis on comprehensive geriatric assessment to inform treatment decisions. Geriatric assessment is an assessment that looks at many of the aspects that geriatricians look at on a daily basis. And those are the 5 M's. Those are mobility, medication, morbidity, mentation, and what matters most to the patient. So geriatric oncology really centers all of these things. It's not just a performance score and then matched with the best treatment. It is really a comprehensive look at the patient. And what happens when we do geriatric assessment is that we can identify what we call vulnerabilities. And so those vulnerabilities might be things like, well, this person is already pre-frail. And if they have treatment, they are going to become frail. So let's get them into an exercise program, or let's look at the term optimize is used a lot in geriatric oncology, which I hate. But let's see if we can optimize this individual's health before they start treatment so that they do well with the treatment rather than develop toxicities and do poorly and then have a poor quality of life. So that's really the essence of geriatric oncology. And according to the American Society of Clinical Oncology, ASCO, and SIOG, all adults over the age of 65 should undergo a geriatric assessment prior to making a treatment decision. And why is that? Why can't they have a geriatric assessment after treatment? Well, the point really is that you have the geriatric assessment, and then all of this information goes to the oncologist or the geriatrician or the geriatric oncologist. And so that when they have a conversation with the patient, they can say, like, look, this is your life expectancy. Here are the potential vulnerabilities. You are good to have normal treatment, or we would suggest a reduced treatment, or do you want to have treatment based on all of these factors? But really allows what we would consider to be shared decision making. And, it is questionable about whether we can actually engage in shared decision making with older adults if we don't have this comprehensive information. And what's beautiful geriatric oncology and what's wonderful about the International Society of Geriatric Oncology, which I will encourage you to join, is that multidisciplinary care is central to geriatric oncology. And we're not talking about multiple disciplines in the sense of multiple physicians from different backgrounds, surgical oncology, radiation oncology, and medical oncology, which is something that we often run into at our oncology conferences. But we're talking about bringing in the physiotherapist, bringing in the occupational therapist, bringing in the psychologist, and working together to make a plan of care that works for the patient. So why do geriatric oncology? Well, we know that it improves quality of life. And in this, on the bottom of the screen here, you can see this review done by my colleague, Dr. Alibai, and his team at Princess Margaret showed that geriatric assessment, sorry, I'm looking at this paper on the right side, showed that geriatric assessment and evaluation through their clinic can save up to $7,000, well, on average, $7,000 per patient. And so there's a cost savings, and that should be motivating for decision makers if nothing else is. And looking at the studies that have been done, because there is quite a strong evidence base now across different regions of the world, private and public healthcare systems, there has been a systematic review and meta-analysis done. This was also completed by Shabir's team at Princess Margaret, which showed that compared with usual care, comprehensive geriatric assessment was not associated with a difference in risk of mortality, hospitalization, treatment discontinuation, or dose reduction, but, and importantly, was associated with a lower risk of treatment toxicity, indicating potential to optimize cancer treatment to this population. And I think for many of us, that is exactly what we're interested in. If folks do choose cancer treatment, we don't want them to have more adverse events as a result of it. So for some of you, many of you, maybe this is the first time that you've thought about geriatric oncology. You're probably wondering, like, if it's so great, why aren't we doing it? And it is really challenging. I can tell you that with my colleagues here in BC, we've been working to develop services in geriatric oncology since 2020. We've done a number of different projects. We've had meetings with decision makers. We've met with parliament, people who are in parliament. We've met with the seniors advocate, and it's starting to develop momentum, but it is very challenging. And so in this review that was led by Chad Han from Australia, we looked at geriatric assessment in older adults and looked at the barriers and strategies to implementation. So, we know what some of these things are, but across all of the literature, what are the challenges? So the first one is service management and governance. I think this is obviously well known to many people. There are multiple competing priorities, and in some ways, for many people, geriatric oncology seems like just another special program. But you'll remember that at the beginning of the call, I did say that geriatric oncology, older adults capture the majority of patients we see, and in BC, up to 80%. So it isn't just a special project for people who need this care. It is actually a large population of folks who need this. And then the second point, resources, staffing, workload, and workforce. We know this is a huge issue. We know that it's challenging to figure out, even if we did have a geriatric oncology program, how would it work? How would we do this? How would we optimize the roles of everyone else in that multidisciplinary team when we know that in Vancouver in particular, we have a shortage of geriatricians? So how would we actually be able to run this program to full capacity, to be able to see everyone over the age of 65 or those who are most frail within all of these confines? There's also professional dynamics. So sometimes we know what the best solution is for this problem, but there are competing demands and there's some paternalism across disciplines that makes it difficult for us to be able to implement these programs. There's also patient-related factors. Maybe there's just too many patients. We do have that problem, so we have to think about risk stratification. And then, there is some question amongst some folks about the clinical utility of geriatric assessment in cancer settings, although there's a lot of evidence now that disputes those sorts of conversations. So this is where I want to talk about the role of nursing in geriatric oncology. And I'll use a couple of examples from here in British Columbia, as well as global examples. And, really emphasizing the fact that geriatric oncology is multidisciplinary. How can we leverage different members of the team? So nurses play a vital role in geriatric oncology and in oncology in general. They conduct assessments, they coordinate care, they deliver key patient and caregiver education. They lead innovations in supportive and survivorship care. And they conduct research and leadership to advance the field. And nurses see patients from the time of diagnosis through the survivorship period. And survivorship care for older adults is going to look different, but that doesn't mean that it's less important. So, why are we talking about nurses and what is the potential for nursing? I think one of the things that I want to emphasize and to think about and get people thinking about is how we can use different members of the team and get them working to full scope to actually optimize care. Nurse-led models can can conduct comprehensive assessment, care coordination, symptom management, and survivorship. Um, Geriatric assessment integration in their practice improves treatment tolerance, quality of life, and decision making. And integrating geriatric assessment with navigation models can help older adults manage complex care pathways. So, what's out there? What's being done so far? I'm going to talk about these two studies, and then I'll mention one that's not published yet. That's currently underway. Um, Nurses have been used as advanced practice nurses to support polypharmacy management, frailty screening, and functional preservation. There's actually also another study out of Australia, a new study that just came out in 2025 about nurse navigation that showed that patients were satisfied with the experience and also had improved quality of life. And there are global examples that demonstrate flexibility across care settings. The gist of it is that in settings where we are struggling with, what kind of physician is available to lead this, whether it's an oncologist or a geriatrician or a geriatric oncologist, there are really opportunities for nursing to take the lead here. Nurses can conduct most of the geriatric assessment where nurses need, and I'm talking about registered nurses working to top of scope. And of course, nurse practitioners having a broader scope of practice can complete the holistic assessment, including things like deprescribing or having conversations about deprescribing, and or be supported by geriatricians. So there are opportunities here. And I think I just spoke to this slide. Unfortunately, I'm sorry, I don't have a preview on. So, geriatric oncology nursing consults. I think really the idea for me is encouraging people to think about nurses working to top of scope. What does that look like, and how can we support that to support older adults? Telehealth for older adults is going to look different. We actually don't know a lot about telehealth for older adults. We talk a lot about it. We hear a lot about concerns. Myself, my team did quite a lot of research about the use of telehealth and e-health during the pandemic, but we haven't done follow-up work. That's something that I'm really interested in doing. And the other point I just want to make about nurse-led models is that in many of the conferences I've been at where we're talking about geriatric assessment and we're talking about, the positive outcomes of this and maybe improve quality of life and reduce treatment toxicity. These are often presented by oncologists at these conferences. The work of what's being done is actually being conducted by registered nurses. And so I think I'm trying to just raise the fact that if this work is being conducted by and supported by registered nurses, when we're doing studies, I know many of you on this call are researchers, but when we're doing studies looking at different models of care, I think it's really helpful to think about the top of scope for folks like nurses, physiotherapists, and other members of the multidisciplinary team who are just as capable of working alongside our oncologist colleagues to implement these types of survivorship programs. And of course, nurses are also leading research in geriatric oncology as well. I again point to my colleague at Princess Margaret, the paper here cited at the top, implementing proactive phone calls for older adults with cancer after systemic therapy. This was a quality improvement project, but showed, improved outcomes with patients and satisfaction. And so nurses are really working in dyads with patients throughout that treatment trajectory. And I think we're starting to get a better understanding of how that dyad actually does have an impact on patient care. And so I just want to bring to the fore one really lovely Canadian example. It was a Canadian sort of international effort, and I did have one of the papers in one of my early slides, but led by my colleague Faye Straushine and alongside Martine Putz from the University of Toronto, we did write a few position statements. Faye led several data collection efforts across Canada to sort of understand the needs of oncology nurses about caring for older adults with cancer. And from this initiative, we developed a geriatric assessment toolkit for oncology nurses. And, the idea really was to say, like, okay, not every center, folks in Sudbury might not be a good example because there is actually a geriatric oncology program there, but um, perhaps folks in Saskatoon don't have a geriatric oncology clinic. But what pieces of the geriatric assessment could they actually implement in their practice? Could they actually do quality improvement initiatives on their own? Could they identify where they could make a change in addition to the things that they're already doing and do that work themselves? And so that's really was the goal of the toolkit, was to put something out there that could support practice. And there have been a few really great examples of that. I just want to see what my next slide is if I actually talk about this. I don't. And so I just wanted to mention an initiative being led by one of our co-directors of the Access Lab, Bonnie Leung at BC Cancer. And she hasn't published this work yet, so I can't, put it on a slide. But essentially, she implemented geriatric screening in the lung tumor group, and her goal was really to get it to 100% screening of all patients over the age of 70. And she just did it as a quality improvement initiative, and now over a year on, she's been able to do that and has had a really good opportunity working with nurses and understanding how this can fit into their practice, and has collected some really interesting data about this process. She'll be presenting those findings at the International Society of Geriatric Oncology in Belgium in November. You're all welcome to come and hear about it, but I'm sure they'll be published shortly. But all this to say is that, from a sort of cross-country listening quality improvement project led by Faye and Martine, came a position statement. From that came the need to develop a tool. The toolkit was developed. And, someone, Bonnie, one person, one example, although there are others, was able to develop a research project with clinical implications, collect this data, and it really is having a transformational impact. Now that we have this data, it's making our conversations with decision makers a little bit easier about how this actually works in practice. And so I think this is a really great example to think about. I realize this is probably a little bit more clinical practicey than researchy for many of you on the call, but I think it's a great example of the research to practice continuum. And this really was a nursing-led process. And so what are the opportunities in the future? I think really thinking about these types of projects, like the one led by Bonnie, which are really focused on implementation. How do we do this? We just had another meeting this week with a different group of nurses within BC Cancer, thinking about how we implement screening. And, each group is different. And I think working from a bottom up rather than a top down approach, as Bonnie has done, has just made such a big difference. We also need to think about, in the geriatric oncology space, how we take our understanding of the needs of our patients, which nurses are very familiar with, and develop interventions. So, for example, I think some of the areas where we can do better or can innovate are around financial toxicity, caregiver burden, and social isolation and loneliness. And I think there's also great opportunities that we've seen for working in participatory research, patient-oriented research with older adults and their caregivers. because they really do have something super valuable to contribute. And really continuing to generate evidence on workforce development and the nursing role integration and how that can be leveraged to improve care for older adults with cancer is really essential given the constraints we face and will face into the future. So, a couple of summary thoughts here. Nurse-led care improves outcomes for older adults with cancer, and I think that there's a lot of opportunity to scale and adapt nurse-led models locally and globally. And I would just like to emphasize that collaboration across disciplines strengthens innovation and impact in survivorship care. And, really in geriatric oncology, we're thinking about how that starts at the time of diagnosis and before treatment in order to give older adults a really good opportunity to make a decision that they're fully informed about. So that's the end of my talk. I think I spoke quickly, and I apologize for that. And I just want to remind folks that the International Society of Geriatric Oncology meeting is taking place in Belgium in 2025, coming up soon. We'd be happy to welcome you. And if geriatric oncology is an area of research or practice you're interested in, please feel free to reach out to me. I don't think I have it in my bio, but I also co-chair the Canadian Network on Aging and Cancer. And we're always looking for folks to come and present and learn and talk about geriatric oncology. So I'll leave it there and I welcome any questions you might have.